Good morning, everyone. So I'm going to talk to you about orthotics. Orthotics is a science and art involved in treating patients with an orthosis. An orthosis is a device applied to the external surface of the body part to achieve one or more of the following goals: to relieve pain, to mobilise, to reduce load, to prevent and correct deformity, and to improve function. Ortho means straight in Greek, and that's where the word orthotis comes from. An orthotist is an allied health professional who assess, prescribe, design, fabricate, fit, modify and educate a patient on the use of an orthosis. The imagery captured in this orthopedic symbol is pretty much what we aim to do. And we are an integral part of the motor neuron disease multidisciplinary team. Orthoses have been used in medicine for over 5,000 years. An Egyptian archaeological discovery of a fracture orthosis in Sudi was published by Smith in 1908. And in this picture you can see an ulnar bone in the middle, and on either side there are linen and bark bandages that wrapped around this fractured limb. And there's reeds in the linen, and there were bloodstains found. There are three main areas that an orthotist targets in motor neuron disease. They are ambulation, which is walking, upper limb hand function, and neck support. This is dependent on the presentation of signs and symptoms in progressive motor neuron disease. Lower motor neuron signs are reflected in muscle weakness, muscle atrophy, cramps, and fasciculations. Upper motor neuron signs are loss of hyperreflexia, loss of dexterity, muscle stiffness or spasticity, and pseudobulbar signs. The three main functional goals of ambulation, of human ambulation, are to move from one place to another, to move safely, and to move efficiently. When motor neuron disease affects the lower limbs, gait is neither safe or energy efficient. Commonly, they present with asymmetrical focal weakness in one limb, and symptoms are more likely to be distal than proximal. That means their weakness is in their foot first, and then it goes to the knee and hip later on, and same with the upper limb. In order to understand abnormal walking, pathological gait, you need to understand normal gait, and it is imperative in order to prescribe the appropriate lower limb orthosis that will address the functional deficits that are presenting. Typical motor neuron disease patients have decreased walking velocity with shorter stride length, shorter stance time, and increased swing time for the involved limb, and asymmetrical gait. Typical deviations of gait. They compensate their movements for foot drop by hip hiking, which is flexing at the hip to clear the foot, or circumduction, which is that rotation of the limb to clear the ground. Foot slapping, which is that uncontrolled movement when their foot lands on the ground, there's a slap because they don't have the muscle power to slow down the foot. And foot drag. More advanced symptoms require ankle support, medial lateral ankle support, not just foot drop. The ankle is weak on all three planes, and knee support. With disease progression, motor neuron disease patients are at risk of falls, they've got reduced balance, and they have reduced walking confidence. I'm just going to show you a small clip to demonstrate the compensatory movements that I've been talking about. So this gentleman has motor neuron disease, and he's got left-sided weakness, and you can see his foot, how it's dropping, and he's really got no control of that foot, and he's hip hiking and he's circumducting with that hip to clear the ground. And I'll just show you the same video from the side. Just concentrate on the left foot. So this gentleman presented with, the onset was lower limb weakness on the left side. They're his only signs at the moment. 5 months ago, he was prescribed with an AFO at another centre. And this did do the job of clearing the ground 5 months ago, but he found that lately it's been really ineffective. So his compensatory movements, you can see his trunk is tilting backwards and he's really trying to bring that leg forward to clear the ground. So in the initial stages of weakness, this is a typical brace that's prescribed. Okay, when you saw me, we tried some other braces to give more medial lateral support and give him that foot lift. This is a carbon fibre prefabricated AFO that's on the market called the Blue Rocker. He really liked this. We tried a few different types of braces, but this was the one that he chose, and we need to fine tune it to get the angles right and make it comfortable, and he found this comfortable with just 6 millimeters heel wedge in there. So he was quite happy with that. So there's improved walking. What can be done? To reduce gait disorders, we really need to optimise the AFO biomechanically. There's a wide range of AFOs out there to choose from. Treating foot drop can be challenging as patients with ALS can have varying muscle weakness and atrophy in both legs. In a paper by Owen, written in 2010, he provides a clinical algorithm for design and tuning of AFOs according to the shank kinematics during stance phase of gait. He initially says to prescribe a leaf spring AFO for foot drop, and later stages get more rigid, and it can get more supportive, and you can use a ground reaction AFO which starts to come up the knee. Muscular atrophy reduces the shank cross-sectional area and makes the AFO ineffective. So as the muscle in the leg atrophies, the AFO doesn't fit as good, and so they really need to come back regularly to an orthotist to make sure that it's fitting well and that it's still appropriate for their weakness. Modifications and retuning of AFOs should be performed to optimise gait regularly. So I have a patient who presented initially with one side leg weakness, the left side. I initially gave her a leaf spring type of AFO, and as the symptoms progressed, we went into a carbon fibre type of AFO to give more support. It's light and gives some energy return, so it's very effective. After a while, her right side started to get weak, so it's not uncommon to see a patient in 2 different braces for the 2 different legs, depending on their weakness. And in this particular case, her knee started to give after a while as the disease progressed, so now we have to look at knee control. If it can't be achieved with the AFO, an orthotist has to look at bracing the leg past the knee, and that's what I'm looking into at the moment. I've almost finished fabricating a knee ankle foot orthosis which locks when she's standing so she can walk safely. Strangely enough, she does have very strong knee extension strength, about 4 negative, but even though it's quite strong when she's sitting, after a while she fatigues and her knee buckles, so that's why I've got to keep her safe. Lately she's gone into her wheelchair and relies on that more because she feels unsafe, but hopefully when I finish my KAFO, she can wear that and be confident to walk again. Okay, upper limb. Usually motor neuron patients present with flail arm, and the initial symptoms can be evenly divided between upper and lower limbs, more likely to be distal than proximal, so in the hand rather than the shoulder first. The main goals are to prolong independence and communication, and therefore quality of life. Usually the hand needs to be held in a functional position in order to operate an iPad or write, especially when they're speech impaired. This is very important in the bulbar onset. So this is an example of a wrist hand orthosis. It's used in the community to treat a lot of conditions. It just supports the wrist when it's weak and frees up the fingers. So I had a gentleman who was 55 years old. He presented with bilateral flail arm motor neuron disease. He also had bulbar motor neuron disease, but that was only affecting his neck muscles. He could only use his thumbs to remove his track pants for toileting. His elbows could not flex but remained in a straight position. He did not want to be confined to a wheelchair as he liked being able to walk around, and his limited hand function was enough for him. It meant he didn't have to go to a nursing home. For others, a wrist hand orthosis puts the hand in a functional position just to give them that ability to pinch and hold objects. Okay, the next thing we treat is neck weakness. So motor neuron disease patients with cervical onset, which is usually bulbar onset, have weak neck muscles. Their head falls forward into a flexed position with the chin on the chest. Bulbar signs involve difficulty swallowing, chewing, breathing, fatigue, weight loss, axial weakness involving neck and trunk muscles. There are various prefabricated soft and hard collars on the market, as can be seen here. The Philadelphia, the Aspen, the Miami J, but these have been designed for spinal cord injuries and really restrict motion in the neck. Foam materials can be modified for comfort and custom fit. But the most commonly prescribed collar for motor neuron disease is the Headmaster Collar because it's more cosmetically acceptable and it allows airflow. Advanced symptoms of facial muscle atrophy and chest intercostal muscle atrophy make this collar difficult to wear. The mandible feels pressure of the weight of the skull on the jaw. They really require something to free the jaw and the chest up from pressure. They complain of discomfort, fear of choking, and difficult breathing, and not to mention difficulty eating for those who are eating. It's challenging for orthotic management in the advanced stages due to the patient's patient intolerance. So this is a description of the forces that are at play here. The first one is the force applied to patient flexing in a collar. So you can see it under the chin and on the sternum. And the forces applied to a flexed firm collar. That's the forces of the patient against the collar. A collar restrains the neck from forward flexion by 3 forces on the mandible, the counterforce on the sternum, and the rear of the collar to prevent the forward displacement of the collar. Really wish there's a solution that could suspend the head without causing all this discomfort. So I tried offloading the mandible. So the first picture is a picture of a Minerva. CTO stands for cervical thoracic orthosis, and a halo, which is a head cervical thoracic orthosis. The first picture, I think a patient would accept this more than the second one. So I went ahead and removed the chin bit and thought, well, we'll suspend the head through a broader strap. So that's an example. My 85-year-old patient with 85 years old who had bulbar onset and flail left arm also had kyphosis, which is the bending forward of the trunk, which was exaggerated when she stood up. Her respiration was compromised. She had a lot of saliva and atrophied facial muscles. She also wore dentures and complained of severe pain in her jaw. She could not cope. So with this brace, which I thought might do the trick, it gave clearance around her peg on the inferior border of that front panel. But she couldn't bear to wear it for more than 15 minutes and returned it. This is another example of a successful attempt from another orthotist who didn't use the whole thoracic posterior and anterior sections, but just designed some metal bars that suspended around a waist belt and held his head in that position, and this was very successful and acceptable for him. However, this man doesn't have any speech or feeding problems, so his symptoms aren't as advanced. But good news is there's a new innovative collar that's going to be on the market, I hope soon. It's led up by a Head Up project, which was led to create a more suitable collar for motor neuron disease patients. It was funded by the National Institute of Health and collaboration with Sheffield teaching hospitals and universities in the UK. It sits low on the neck and follows the contours of the neck. And some patients' comment on this was that it will give great relief to motor neuron disease patients. My 85-year-old female patient with a bulbar onset and flail arm was the most challenging as an orthotist. I was not able to get her comfortable. I was not able to achieve an acceptable cosmesis. You're not always going to win as a therapist. Their dignity comes first. Orthotics are available to provide the most freedom and safety possible and preserving dignity, choice and quality of life. I will always give my motor neuron disease patients options to choose from various orthoses and abandon them when they're no longer useful but a barrier. Cosmesis is very important as well as function. They don't want to draw more attention than they have to, and sometimes you've just got to accept what's best for them. So, please refer to an orthotist for patient review regularly, especially as the motor neuron disease progresses. Please include an orthotist in your motor neuron disease clinic, and hopefully the Motor Neuron Disease Association will encourage and support research in the area of orthotics, focusing on patient benefits and barriers of orthotic use and patient-driven orthotic innovation. Multi-factor nature of ALS deficits demands a coordinated, multidisciplinary team approach. Orthotic intervention aims to maximise patient safety and balance in walking. It aims to assist with upper limb hand function, to assist with their communication, and it also aims to support their head and preserve their dignity, give them that eye contact, assist with the communication, assist with their breathing and their feeding if possible, and to preserve their dignity and quality of life. Thank you very much.